Okay, as part of this relationship, you want always to do the least necessary. So you start with small amounts of medication and you work up. If you can treat them as an outpatient, you do that rather than have them as an inpatient. If they need a section, the first time should be a section 2 and not a section 3. If you can persuade them to take medicines by mouth, then that's better than long-acting depot injections. You may need to come to all the others. They may need to be admitted. They may need a section 3. They may need long-acting depot injections. But you should start small and work up gradually. You should give adequate medication. You must give enough to suppress the florid symptoms. And incidentally, all medication is better at suppressing the florid symptoms of schizophrenia and less good at the negative symptoms of schizophrenia. All medicines have side effects. Most of them are sedating. Most of them will cause weight gain, tend to cause increased prolactin, and that can lead to lacturia. Young men develop impotence, which is especially distressing for them, and they may well not tell you unless you ask about it. There are the dyskinesias, Parkinson's symptoms. You can get an acute dyskinesia. And I can remember there was this man in his 40s. He was a successful businessman. He had a family. He was established. And then he developed a severe paranoid illness. He was a big man, and there was the threat of violence, so he ended up in a locked ward in a big traditional mental hospital where we treated him. And he had an ocular gyrate crisis. He got very well. He went out of hospital. He continued medication. We followed him up for years. But the most terrifying memory that he had was not of his paranoid delusions, was not being sectioned, was not coming into an old-fashioned locked ward. It was having the ocular gyrate crisis. So one needs to try and avoid side effects. We have the worry about tardive dyskinesia. And when this sets in, it can be difficult to help, and it's likely to happen after long-term medication, and yet the medicines have to be long-term, and the dosage needs to be enough to control the symptoms. So it's a fine balancing act to continue medicines at the least amount necessary for the illness. Some of the medicines prolong the QT interval, and this can increase the chances of dropping dead, which obviously is something to be avoided. However, all that I've said applies predominantly to the older medications, and we now have newer medicines which are equally effective in coping with schizophrenia and have much less in the way of side effects. Of course, they don't have no side effects. Olanzapine does have the tendency to weight gain. People can still get Parkinsonian symptoms under risperidone. Both of these two, if given to the elderly, actually increase the chances of a cerebrovascular accident. The earliest new antipsychotic actually was clozapine, which is particularly good in avoiding tardive dyskinesia. The trouble with clozapine is that it can cause neutropenia, and sometimes that goes on to agranulocytosis, which can lead to death. The last statistic I heard was 1 in 3,000, so it's not likely, but if one of your patients is on clozapine and they develop a sore throat, worry. NICE have issued guidelines on the medicines to be given in schizophrenia, and they say that you should start with one of the newer antipsychotics. They don't say this, but quetiapine seems to be one of them which is lowest in side effects. They say that if somebody is on the older antipsychotics and they're having trouble with side effects, then you should shift them gradually to one of the newer antipsychotics. But if somebody is well established on an older antipsychotic and they're not particularly troubled with side effects, then you should keep on with them as you are.